بسم الله الرحمن الرحيم. Floppy infant syndrome. Our objective is to characterize the clinical signs of generalized hypotonia, describe the difference between central and peripheral causes of hypotonia, generate a differential diagnosis of hypotonia in infant, and discuss the appropriate evaluation and management of floppy infant. A 9-month-old male infant is brought to your office for evaluation of developmental delay. The patient was born at full term by normal spontaneous vaginal delivery. The pregnancy was uncomplicated and fetal movement was reported to be normal. There were no feeding or breathing difficulties after birth. He appeared to be developing normally until the age of 5 months, when he seemed to get weaker. His parents noticed that he was having difficulty holding his head up, and he stopped reaching up with his arm to grab toys. At the age of 7 months, he still couldn't roll over or sit up. He recently started to have some difficulty swallowing and may cough with meals. The infant has head support. He has also active palmar grasp and he has bubbling. Gross motor development, he has head support like 3-month-old infant, and his fine motor development, he has active palmar grasp also like a 3-month-old infant. His social development, he can respond to his name when called, that's like a 9-month-old infant, and the language development, he has bubbling like the 9-month-old infant. And so on assessing his developmental quotient, the developmental age of this infant is a 6 months of age, 6 months, and dividing his developmental age by chronological age, he will get, so the DQ will be 66. The general examination, his vital signs were normal. His weight is below the 5th percentile. He has a bell-shaped chest, paradoxical respiration, and frog-leg position. There is no dysmorphic facial features. Neurological examination, mental status, he is alert and visually attentive. Language, bubbling. Cranial nerve examination, we can see that he has a tongue fasciculation, and also the other abnormality is that gag reflex is absent. The motor system, he has muscle wasting, generalized hypotonia, and diffuse weakness. The patient is unable to lift his arm or leg against the gravity, and some movement of his hand and feet is only present. There is a very poor head control. So in motor system examination, there is weakness and there is hypotonia and muscle wasting. Sensory system, he has withdrawal and glimpsing to pain, so intact pain sensation. Reflexes, there is absent deep reflexes, the bilateral plantar flexor response. So in conclusion, our patient is a 9-month-old boy with a significant gross motor delay, progressive weakness, dysphagia, and he had a bell-shaped chest, paradoxical respiration, tongue fasciculation, hypotonia, and proximal weakness and areflexia. So we had an infant with generalized hypotonia, so our diagnosis is floppy infant syndrome. Floppy infant syndrome is generalized hypotonia in the first year of life. What are the signs of generalized hypotonia? The frog leg position is one of the signs of generalized hypotonia. Also, the head lag on ball to set maneuver or traction response is one of the signs of generalized hypotonia. Head lag on pull to set maneuver or on traction response. The head is lagging behind the trunk. On ventral suspension, there is inverted U posture, while on vertical suspension, the infant with generalized hypotonia will show slipping from your hand on vertical suspension. Comparing it to a normal infant who will hold his shoulder above your hand. Signs of generalized hypotonia are frog leg position, head lag on traction response, inverted U posture on ventral suspension, and slipping from your hand on vertical suspension. What are the causes of floppy infant syndrome? We can divide the causes of generalized hypotonia in the first year of life. Could be due to central cause, and it's called central hypotonia, either due to brain or spinal cord lesion, or it could be due to neuromuscular disorders. So the floppy infant syndrome could be due to CNS cause, that is the central hypotonia, or due to neuromuscular disorder. CNS, it could be either brain or spinal cord lesion, and neuromuscular disorder is either a lesion in the anterior horn cell, in the peripheral nerve, in the neuromuscular junction, or in the muscle. So floppy infant syndrome could be either due to central cause or due to neuromuscular disorder, and the neuromuscular disorders could be either anterior horn cell disease, peripheral nerve lesion, neuromuscular junction disorder, or due to muscle disorder. Example of central hypotonia due to brain or cerebral hypotonia is cerebral palsy, chromosomal disorder like Down syndrome, congenital anomalies of cerebellum. Central hypotonia could be also due to spinal cord lesion like trauma to the spinal cord during birth injury, for example, or spinal cord hypoxia or ischemia. Neuromuscular causes of floppy infant could be anterior horn cell lesion like Varding-Hoffmann disease and neonatal poliomyelitis. Also, peripheral nerve lesion could be a cause for floppy infant syndrome. Mostly it is hereditary neuropathy, and rarely it is Guillain-Barré syndrome. Neuromuscular junction disorder could be also a cause for floppy infant syndrome, and infantile botulism, transient neonatal myasthenia gravis, and congenital myasthenia gravis are the major example of neuromuscular junction disorders that can present as a floppy infant syndrome. Muscle disorder, for example, congenital myopathy and congenital muscular dystrophy are the main muscle disorders that can present as floppy infant syndrome. How to distinguish central from peripheral or neuromuscular causes of hypotonia? Infants with central hypotonia will usually have cerebral manifestation, mainly epilepsy, intellectual disability, or microcephaly. On the other hand, infants with peripheral hypotonia will not have epilepsy, and they will usually have a normal mentality. Dysmorphic features may be present in infants with central hypotonia, like in children with chromosomal disorders. For example, Down syndrome will have the mongoloid facies. The upper motor neuron signs will be present in infants may be present in central hypotonia, while infants with peripheral hypotonia will have the signs of lower motor neuron lesion, mainly in the form of weakness, wasting, and diminished or absent deep reflexes. So, an infant infant with generalized hypotonia and with peripheral hypotonia will have no epilepsy, normal mentality, they will have weakness, wasting, and deep reflexes. On the other hand, infant with central hypotonia may have epilepsy, intellectual disability, microcephaly, they may have dysmorphic features, and usually they will have the deep reflexes will be normal or maybe exaggerated with clonus like in atonic cerebral palsy. Investigation for causes of Floppy infant syndrome. In central hypotonia, you should ask for MRI brain, and you may also ask for a karyotyping if you suspect a chromosomal disorder. In peripheral hypotonia, you should ask for creatinine phosphokinase, EMG, nerve conduction study, and you may even ask for a muscle or nerve biopsy. Spinal muscular atrophy is an autosomal recessive genetic disorder characterized by progressive degeneration of the anterior horn cell, so it is a neuromuscular disorder. Clinical manifestation of spinal muscular atrophy: there is signs of lower motor neuron lesion, weakness, wasting, hypotonia, and absent deep reflexes. The onset of weakness may start very early, before the age of 6 months, that is the type 1 spinal muscular atrophy, or it is called Verding-Hoffmann disease. Type 2 spinal muscular atrophy, or the late infantile form of spinal muscular atrophy, the onset of weakness start after the age of 6 months. While type 3 spinal muscular atrophy is a juvenile form, the onset of weakness start after the age of 1.5 years. Neonatal and late infantile spinal muscular atrophy have short lifespan due to respiratory muscle paralysis and recurrent chest infection, while type 3 has a normal life expectancy. Verding-Hoffmann disease, or the infantile form of spinal muscular atrophy, or type 1 spinal muscular atrophy, it is the commonest cause of Floppy infant. It is autosomal recessive, characterized by progressive weakness, decreased spontaneous movement, muscle atrophy, areflexia, bulbar palsy in the form of weak cough and cry, visible tongue fasciculation, sparing of extraocular muscle, strictures, and cardiac muscle. The infant will have delayed motor development, while the other developmental milestones are normal. He has normal mentality. EMG will show fasciculation and fibrillation at rest, and the diagnosis is mainly based on genetic testing for survival motor neuron protein gene deletion. 2/3 of infants will die before the age of 2 years if they didn't receive the treatment, and the treatment for spinal muscular atrophy become available around the age of 2018 in the form of gene replacement therapy. الحمد لله، مصر بدأت علاج أطفال السباينال ماسكولار أتروفي اللي هو ضمور العضلات الشوكي بداية من سنة 2021. في النص الأخير من سنة 2021 مصر بدأت التريتمنت of spinal muscular atrophy in the form of the gene replacement therapy. هنرجع تاني للإنفانت اللي احنا شفناه في أول المحاضرة. We have diagnosed him as Floppy infant syndrome, but is it central hypotonia or peripheral hypotonia? Both central and peripheral causes must be considered in the differential diagnosis of hypotonic infant. The patient's symptom localized to the peripheral nervous system, and the disorder of anterior horn cell, peripheral nerve, neuromuscular junction, and muscle should be considered. So our infant is a Floppy infant syndrome due to a peripheral cause of hypotonia. It is either anterior horn cell disease, peripheral nerve, neuromuscular junction, or muscle. Why we diagnose him as a peripheral cause of hypotonia? Because the infant has no history of cognitive delay or other cerebral manifestation like seizure. There is no epilepsy or seizure, so there is no cerebral manifestation that point to a central cause. Given the history and the cranial nerve findings, there is no history of birth or other trauma in this patient, and there is no sensory level or sphincter abnormality, so we are excluding spinal cord lesion also. The presence of hypotonia, weakness, and absent deep reflexes point to a lower motor neuron lesion. It is either a disorder of anterior horn cell, or peripheral nerve, or neuromuscular junction, or a muscle disorder. How to differentiate? Tongue fasciculation indicate the involvement of the hypoglossal nerve, and it is usually indicative of anterior horn cell disease. On the other hand, polyneuropathy is a rare cause of generalized hypotonia in the first year of life, and usually an infant with hereditary neuropathy will have a distal more than proximal weakness and will have stock and glove hypoesthesia, while our infant had an intact pain sensation. Considering also congenital neuromuscular junction disorders such as congenital myasthenia gravis, the infant with congenital myasthenia gravis will usually have ptosis, and our infant didn't have ptosis. Our patient is a Floppy infant syndrome, most probably due to neuromuscular disorder, most probably anterior horn cell disease, and it is most probably a spinal muscular atrophy, the infantile form of spinal muscular atrophy, or type 1 spinal muscular atrophy that is called Verding-Hoffmann disease. Benign congenital hypotonia is another cause of Floppy infant syndrome. It's non-progressive hypotonia of unknown etiology. The infant will have delayed motor development. On the other hand, his social and language development will be normal, and his neurological examination will be normal except for the presence of hypotonia. It is usually of good prognosis, and usually the infant will develop normally later on. He will have a normal CBK, EMG, nerve conduction study, and normal MRI of the brain. Polyneuropathy could be a cause of generalized hypotonia in the first year of life. Hereditary polyneuropathy and Guillain-Barré syndrome are examples of polyneuropathy that can present in the first year of life. They have characteristic clinical finding of bilateral and symmetrical weakness, absent deep tendon reflexes, glove and stock hypoesthesia. Nerve conduction study will show delayed nerve conduction velocity, and the EMG is normal. Disorder of neuromuscular transmission that can present as Floppy infant syndrome are infantile botulism, congenital myasthenia gravis, and transient neonatal myasthenia gravis. These disorders are characterized by external ophthalmoplegia, diminished or absent deep tendon reflexes, and EMG is diagnostic. Infant botulism usually present with an acute onset of descending flaccid paralysis. Primary muscle disease like congenital myopathy and congenital muscular dystrophy could be a cause for generalized hypotonia in the first year of life. The muscle disease are characterized by bilateral and symmetrical proximal weakness, hypotonia and diminished deep tendon reflexes, no sensory changes or excretory changes. The CBK is elevated in congenital muscular dystrophy, and EMG will show myopathic pattern. جزاكم الله خيرا.